Welcome to the Bariatric Surgery Patient Information Seminar at the Alta Summit Medical Center. In this seminar, we're going to discuss the Alta Summit Medical Center Bariatric Surgery Program. We're going to talk about obesity and its effects. We're going to talk about why we treat obesity, and then finally we will talk about different surgical options for obesity. So why choose Alta Summit Medical Center for Bariatric Surgery? Well, several reasons. First, we are a comprehensive multidisciplinary bariatric surgery program. We are also an accredited center of excellence in this area, accreditation by the American College of Surgeons. We started this program in 2003, so over 15 years experience. We've performed over 2,400 cases with a very low mortality, less than 1 in 1,000, which is below the national average. Our readmission rate is very low, and our major complication reoperation rate is also below the national average for accredited center of excellence. Over 99.9% cases are done through small incision, either laparoscopic or robotic surgery. We are also an early adopters and pioneers in robotic bariatric surgery. In the last 5-6 years, several programs have started using robotic surgery, but we started way early in 2006. So we have quite a lot of experience with robotic surgery. We do clinical research. We have a teaching program. We have a fellowship training in our program. We publish and present our research and clinical data, papers, posters, and national and international conferences. Majority of patients have done very well. Our comprehensive multidisciplinary team includes a program coordinator, 3 bariatric surgeons, a bariatric care clinical therapist, clinical RN, a registered dietitian, trained nursing staff, access to physical therapy, access to pulmonologists and cardiologists, as well as other specialists. Meet our clinic staff. Yvette is our patient navigator. Myra is the clinic therapist. Michelle is the clinic dietitian. Catherine is clinic RN. And Helen Johnson is our bariatric surgery coordinator. The 3 bariatric surgeons are Dr. Teresa Kim, Dr. Gregory Broderick-Villa, and myself. So regarding obesity, the first question is, how do I know whether I'm overweight? Or what's the severity of my obesity? So this is done by calculating your body mass index, and this is the formula for that. That gives you these numbers. So if your BMI is between 18 and 25, that's normal weight. Between 25 to 30 is overweight. Over 30 is obesity, and over 35 is severe obesity. Rather than using that complicated formula, the 2 easy way to find your BMI, one is a BMI chart that you can find on the internet, and that gives you, if you put your weight and then height, it'll gives you whether you're obese or morbidly obese. And another simple way is to just on the internet look for a BMI calculator, and you can go to ASMBS website or our hospital website, and you put in your weight and height, and that gives you your BMI. So why treat obesity? So first thing, we know that obesity increases risk for certain chronic diseases. For example, diabetes. In a normal BMI patient, the incidence is 4%, and it goes up to 26% in patients who have BMI over 40. Similarly, asthma, arthritis, high blood pressure, and even cancer. Patient with BMI 40 and above, the risk of cancer goes up from 3% to about 52%. We also know that a high BMI causes death. So patients who have BMI over 40, they have about 2.5 times or 250% higher risk of death. So a patient with BMI 45 will lose about 20 years of their life because of a higher mortality. We also know that treating obesity, whether it is medical treatment for patients who are overweight and class 1 obesity, or surgery, which is reserved for severe obesity and morbid obesity, both ways, the weight loss helps, number one, reduce the need for prescription medications. Number two, increases your overall health. Number three, certain chronic diseases, for example, sleep apnea, diabetes, they may be even cured, certainly improved, but may be cured. Weight loss will extend your life. It will also reduce the chances of having certain cancers. So there are multiple benefits of losing weight or treating obesity. The National Institute of Health indication for bariatric surgery is anybody with a BMI over 40 without any coexisting medical condition, or BMI 35 with at least one or more of obesity-related medical condition. This could be diabetes, high blood pressure, high cholesterol, sleep apnea, etc. So who is a surgical candidate? Apart from meeting the NIH criteria for BMI, there should be no endocrine cause of obesity. For example, if you have hypothyroidism that causes obesity, then it needs to be treated first. It should be an acceptable operative risk. Patient must understand surgery and its risks involved. There should be a good understanding of that. Absence of drug or alcohol problem. No uncontrolled psychological condition. For example, if there's an acute depression, then that needs to be treated first before undergoing surgery. There has to be a consensus after all these consultation with the different members of the bariatric team, and so then it is evaluated by the whole team, and a decision about the suitability is made by a consensus. Patients should be dedicated to lifestyle changes and long-term follow-up care for a long-term success. Now, there are certain patients who should not undergo surgery. For example, history of substance abuse or major psychiatric problem that are untreated or uncontrolled. Again, surgery may be too high risk for a particular person based on their medical condition. Patients over the age of 65 are evaluated on an individual basis, and we have successfully performed surgery in patients over the age of 65. Patients with a history of binge eating do poorly after bariatric surgery. So how is surgery performed? Well, majority of the cases, over 99%, are done through what is called a minimally invasive approach, where several small incisions are made, as shown on the cartoon on the left side, and these plastic ports are placed, and then instruments and cameras are placed through that, either laparoscopic or robotic surgery. Rarely we will perform the old-fashioned way, an incision up and down, as shown on the cartoon on the right side. The advantages of laparoscopic surgery is reduced length of stay, there's less pain, there are less complications, and quicker return to work. Robotic surgery is again a type of laparoscopic surgery, but slightly more sophisticated instruments are used. And we think in particularly patient with very high BMI, robotic surgery may have some additional benefits. The two most common operations performed in the United States and also in our program are sleeve gastrectomy and gastric bypass. So like I mentioned, sleeve gastrectomy is the most common operation performed today. In fact, if you look at the data from 2011 onwards, sleeve gastrectomy in 2018, about 61% of procedures for sleeve gastrectomy and only 17% were gastric bypass.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters and is about the size of a banana. The resected portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. Bile and pancreatic fluid from the liver and pancreas mix with food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or postoperative adjustments needed for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So this is a real intraoperative picture from one of my patients. As you can see, on the left side is the sleeve part, which is left behind, and the large portion is being removed, thereby converting basically a football-sized stomach to a banana-shaped on-size stomach. The overall complication of sleeve gastrectomy is very low. A staple line leak, which could be serious at times, is seen in about 1 to 3% of patients. Small leaks will seal on its own. Medium-sized leaks may need a stent placement by an endoscopic approach, and rarely patient needs to go back to the operating room for suture closure of the leak. Again, postoperative bleeding, not very common, very rare, about less than 1%. Some patient will need transfusion. Most of the time, bleeding will stop on its own. And again, rarely in 1 of 400 or 500 cases, patient needs to go back to the operating room to stop the bleeding. The other complication that you see with sleeve gastrectomy is sometimes you see a narrowing of the sleeve, either a twist or a curve, which can lead to sort of persistent heartburn, which is treated by medical condition and some other means. Now, a gastric bypass operation is a little more complex and slightly more complications. But in summary, we create a small pouch, about 3 to 4 ounces, and then there's some rerouting of the intestine. The main stomach remains in the body compared to sleeve gastrectomy, where 75 to 80% of the stomach is completely removed from the body.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a gastric bypass, a small pouch is created in the stomach using a stapling device. The small stomach pouch, about the size of an egg, limits the amount of food you can eat before feeling full. The small bowel is separated into 2 sections. The lower portion of the small bowel is attached to the newly created stomach pouch. This allows food to pass directly into the second portion of small bowel, where digestion continues. The upper portion of the small bowel is reconnected to the lower. Bile and pancreatic fluids from the liver and pancreas allow food to be digested completely. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So similar to sleeve gastrectomy, a gastric bypass also has a staple 9 leak incidence, which is about 1 to 200 to 400 patients occurs between 2 to 8 days after surgery. Rarely a leak appears late. Symptoms are usually fever and abdominal pain, high heart rate, low urine output, and in some cases you have to go back to the operating room to fix the leak. Overall complication rate is higher for bypass, like I said, about 15% if you include minor complication like minor wound infection, nausea, dehydration, readmission for these things. But major complication rates are again less than 3%. One of the troublesome thing with gastric bypass is developing an ulcer between the pouch and where the intestine is rerouted and is connected to the pouch, particularly in patients who have been either smokers, ex-smokers, or currently smoking, or patients who are using Motrin or similar NSAID class of pain medication. The ulcers in that area can cause either stenosis or narrowing, or it can even cause perforation. Also, in some patients, you can get an internal hernia that can cause blockage of the intestine. And dumping syndrome is seen in about 10 to 15% of patients, and it could be troublesome in some patients. So there are some long-term issues, both with sleeve gastrectomy and gastric bypass, more so with the gastric bypass because there's rerouting of the intestine. So there could be a vitamin, mineral, or calcium deficiency. So patient needs to take these. Some patient will get anemia because of weight loss. Some patient will have skin changes and may require subsequent plastic surgery. And about 10 to 12% of patients will regain weight over a long period of time. So what procedure is right for you? Well, we take a individualized approach tailored to each patient. So it depends upon what medical conditions are present. Do you have diabetes? Is there inflammatory bowel disease? The history of anemia? Is there severe heartburn? It may depend on the upper GI study, which is an X-ray of the stomach, and an endoscopy. Rarely, the decision is made at the time of surgery, and it depends upon internal anatomy and any amount of scarring that you may have from previous surgery. We use a risk-benefit calculator to give an individual risk score for the patient, and sometimes that'll help us decide which operation is better suited for you. Bariatric surgery is one of the very safe operations performed today, with a mortality rate of 0.1%, which is 1 in 1,000. When you compare that to gallbladder surgery and hip replacement surgery, which are the two very common operations performed, bariatric surgery is much safer than those two surgeries. So we're going to talk briefly about super obesity, and super obesity is defined as a BMI from 50 and above. So patient with the BMI of 50 or greater are at a slightly increased risk with bariatric surgery. So in this patient population, we use certain risk reduction strategies. For example, we will sometimes do a two-stage procedure. As a first step, we will do a sleeve gastrectomy, and we will also try to have pre-surgery weight loss. And that helps, again, by reducing the complication rate. So patient with the BMI over 50 or so-called super obese, the first stage will be a sleeve gastrectomy procedure. Even patient with 400 pound and 500 pound, In over 85% of patients, that is enough. Only 15% of patients will subsequently need a second stage procedure where we will add a little bit of bypass or use the intestine, connect it to the sleeve to bypass part of the intestine in something what is called a SIPS procedure or even a gastric bypass, a standard gastric bypass. So SIPS procedure, also known as single loop DS or a SADI procedure, is an added modification to the sleeve gastrectomy, and it actually comes from a standard duodenal switch procedures which has been done for over 40 years, but has been modified in order to reduce the complication of the standard DS procedure. And this is done sometime as a second stage procedure in super obese patients or even as a one-step procedure. So post-surgery, well, bariatric surgery is a tool to help lose weight. And like all other tools, it requires proper maintenance and attention over time in order to ensure its proper functioning. You need weekly weighing, portion control is important, and daily exercise is absolutely important to not gain weight after your weight has been stabilized. So you need about 150 minutes per week, which is 30 minutes, 5 days a week of moderate intensity aerobic activity, and at least 2 days or maybe 3 days of muscle strengthening activities, core muscles, so make your muscle work harder. You can choose anything you want, you can walk, you can run, you can dance, swimming, so whatever you like, but this is really very important to maintain long-term weight loss after bariatric surgery. After surgery, 2 to 3 days in the hospital, initial follow-up at 2 and 4 weeks, and then 3-month follow-up, 6-month follow-up, and finally yearly follow-up. So post-surgery diet starts with clear liquids for 1 to 2 days and is gradually advanced to, in about a month to 6 weeks, most people are eating regular food. Aim is to get about 70 grams of protein, 64 ounces of fluid, small portions, no concentrated sweets, no carbonated drinks, and of course take your vitamins, calcium, and mineral supplements. So our program requirements are a nutritional consultation and education, at least one preoperative support group meeting attendance, a psychological evaluation, a preoperative weight loss, 10% ideal, but between 5 and 10%. Also, a patient must have a regional understanding of the necessary diet and lifestyle changes required to make the surgery successful. So while you're preparing for surgery, try to learn as much as you can about bariatric surgery. Studies have shown that there is a 30% transfer rate of addiction pain medication, alcohol, cigarettes, shopping, and even gambling. If you're a smoker, quit smoking at least 3 months prior to surgery. You should be absence of any alcohol or drug abuse at least 1 year prior to surgery. Establish a support system and start increasing your awareness of your eating habits. So there are several psychological changes have been observed following bariatric surgery. For example, some patients who have prior substance abuse, they are at an increased risk for relapse. Alcohol is absorbed quicker, and so you are at a high risk of DUI. Some individuals may suffer from social anxiety. Once the weight is lost, there is potential for increased anxiety with increased social demands. Again, prior to surgery, patient may not be aware of their association of stress and emotions to overeating. So this could be defined as referred to as an addiction to sugar. There is some emotional eating. If it is not addressed post-surgery, patient may struggle with staying on a post-operative surgery diet and hence a risk of weight regain. So be open to therapy if necessary. So talking about expectations. So first thing is there's no such thing as emergency bariatric surgery. Again, also patients who take time to properly prepare for surgery, they tend to be the most successful. Again, surgery after your consultation may take about 4 to 6 months, depending on your insurance requirement, if it is a 3-month, 4-month, or 6-month medical weight loss requirement. Take time to increase your self-awareness, learn what sets off the food craving, and you'll be better prepared for surgery. So the next step towards bariatric surgery is, if you are interested, then go ahead and complete the medical history questionnaire and take the post information seminar quiz. Send it to our clinic either by fax or mail. Our address is as listed, the telephone number and fax number. So you can call on those numbers and get the questionnaire and the quiz. And once we receive your medical questionnaire and your completed quiz, we will verify your insurance and call you to schedule an initial appointment with one of the surgeons. Please note that due to COVID-19 pandemic, there are new hospital policies for appointments, and our clinic staff will give you specific instructions regarding that. Thank you for your interest in our program.